So it's my pleasure to introduce our last speaker, who will also sort of bring us into the discussion part. I can see everyone's chomping at the bit to chat and ask questions. So this is Lauren Cohee. She is from the Division of Malaria Research at the University of Maryland School of Medicine and works in Malawi with Dawn and me. Welcome.
Thank you, Miriam. I'm going to try to pull things together a little bit and talk about where we go from here, and particularly the results of a systematic review of school-based treatment interventions and considerations of key factors for designing future interventions. I've been working on this project with medical librarian Andrea Schiffer at University of Maryland, and then colleagues at the London School. Charles Opondo has been working with us on the statistical analysis, and Jorge Cano will be working on the transmission evaluation, which I'll share. So just to review kind of where we've come this morning, Dawn showed us some compelling evidence that malaria is common in school-age children, and that infection is associated with anemia, school absences, lower school performance, and then Bronner showed us, and Catherine showed us about the role in continued transmission. So that leads us to ask, can treating school-age children for malaria decrease infection and adverse outcomes? So there was a prior systematic review that was published in 2015. It evaluated 5 trials at that point and showed a significant protective effect against parasitemia and clinical malaria, and limited protective effect against anemia. However, the limitations of this review were that there are a lot of significant design variations among these studies, and only a study-level analysis was conducted. In the intervening 2 years, a number of studies have been published or conducted and identified and as not yet published. So the group I mentioned, we decided that it was worthwhile to conduct a subsequent review and meta-analysis with the aim of determining if providing anti-malarial treatment to asymptomatic school-age children can decrease prevalence of parasitemia and decrease prevalence of anemia. We plan to analyze at both a study level as well as the individual level to help control for variations in study design. And these variations include the type of anti-malarial drug used in the study, the number of doses provided and the interval between the doses, as well as whether the intervention was provided to all students or whether a screen and treat model was involved. And then we also aim to evaluate results stratified by transmission level. And this is our flow diagram of the trials we identified. We started with screening 513 studies and ultimately have identified 12 studies to include in the final review. This was all done with the help of a medical librarian, and a detailed protocol is provided in the Prospero registry. So just to review the timeline and geography and general design features of the studies involved, the first study we identified was conducted by Weiss et al. In 1995. This was an individually randomized trial with multiple arms and included 244 children. Next came Clark's kind of major study published in The Lancet in 2008, which was a cluster randomized study using SP and amidiaquin in about 5,000 children in Kenya. Then Barger in Mali conducted an individually randomized trial with 2 arms and about 300 students. Roner in Cote d'Ivoire, an individually randomized study using SP. Nankabirwa in Uganda conducted an individually randomized trial with multiple arms enrolling about 800 children. Halliday et al. Conducted a cluster randomized trial using AL. Of note, this is the only screen and treat based intervention, and I'll show that later. Enrolling about 4,000 children. Then Nankabirwa followed up her first study with an individually randomized trial looking at 2 different dosing intervals of DP in 700 children in Uganda. Opuku in Ghana in 2016, an individually randomized trial using AL. Montangila published this year a study in the Congo using multiple different drugs in 300 students. Sean Clark published this year a cluster randomized trial using SPR testunate in about 2,000 students. She also has a study from Senegal that's cluster randomized and not yet published. And then we have the results of Catherine and Sarah Stedke's study in Uganda. So this table highlights the variations in study design among the studies. So studies used a variety of different drugs and drug combinations. Of note, 3 studies used SP only. Multiple other studies, again, used non-ACTs, not plus or minus SP in another drug, and then about half of the studies used an ACT. There's variation in the frequency and interval between the dosing from once daily, monthly, and then up to once every school term. The unit of randomization varied between individual and cluster randomized trials. And then again, the Halliday study I mentioned used RDTs as a screening test. And then not included in this table is there's also variation in when the outcome measures were conducted. I'm going to show you today the results of our study level analyses. The individual level analysis is still ongoing. But what you can see here is that combining all of these studies, these forest plots, we do see an overall decrease in the relative risk of parasitemia that was significant. There's variation in particular by drug type. So SP alone did not appear to be effective, and there are the 3 studies involving SP alone. AL alone, artemether lumefantrine alone, also did not appear to be effective, although again that includes the screen and treat based intervention. But the other ACTs were highly effective. When we look at the study level results of anemia, again we see a decrease, though more modest, in the relative risk, and we see similar patterns by drug type. Again, the same is true when looking at clinical malaria, although I would note that there are many fewer studies that followed this as an outcome, and often they were the studies with much more intensive, more frequent drug dosing and more intensive follow-up. So again, we plan to do an individual participant data meta-analysis. So this will pull each individual and will result in about 15,000 data points. We'll use a hierarchical generalized linear model to estimate the risk ratios for the effective treatment, and we'll be able to control for covariates like drug type, the dosing and frequency, and we'll be able to look at drug resistance levels at the time the study was conducted, and then again look at transmission intensity. We'll categorize each location based on transmission setting using baseline prevalence data from the site itself when that's available, or and when that's not available using estimates from the Malaria Atlas Project. So the take-home points are that there have been a substantial number of trials treating asymptomatic children in schools, and that treatment does appear to decrease the prevalence of infection and anemia, and the greatest effect is seen with ACTs. I think this all pulls together substantial evidence that that these outcomes improve, and then hopefully additional trials will demonstrate the connection and the benefit to improve educational outcomes, although they are much more challenging to measure. And then future studies looking at the decrease in transmission potential. So there are remaining questions for this as an intervention. Is it appropriate for all transmission settings? We're hopeful that we'll be able to address this somewhat with our transmission setting level analysis. And then do we need to tailor drug choice, interval, and even potentially could we tailor the age group at which this intervention would be applied to based on the exact epidemiological settings? I'd like to thank all of the individual study authors who have contributed their individual level data to this effort. So I think that's it, and we'll move us into the discussion. I'd like to ask the other speakers to come up to the platform. And again, for those, I'll sort of, again, summarize, and then as much as, we would like any and all questions from you all, we'd also like to foster a discussion of points of sort of how do we move this forward. So again, malaria in school-age children is underappreciated. Dawn showed us evidence that school-age children are probably sicker than we think and are not adequately accessing care. When treatment is available in schools, many children sought treatment. It's not clear then what the role for providing either access to care or treatment of asymptomatic children is in control efforts. We've seen that IPT leads to a decrease in malaria as well as an infection and disease. And then there is the possibility that this does improve school attendance and school performance. But as Bronner and Catherine showed us, there's potential that this intervention could have impacts beyond the individual. Gameta site infectiousness and biting data show that school-age children do contribute as much as adults to transmission and disproportionately to their representation in the population. Catherine showed us the first study that's really designed to address this and showed a decrease in community-level malaria and EIR, although modest, and in the setting of a study with lots of challenges to obtain good, steady coverage, which I think is a challenge as much as we sort of see schools as being an easy access group. Her study pointed out the challenges in working with this group. And some of those challenges are related to conducting studies and may not necessarily be there in the setting of programmatic implementation, but how to balance that and determine the true potential for impact as a program in the research setting is a challenge. She identified implementation challenges, including consenting, frequent absences, and needs to track children into their homes. Then we have challenges of the selection of drugs and concerns about the potential for resistance. And then how do we best measure the impact of these interventions? So I'm going to leave these questions up, but also welcome anyone to come forward and let's have a discussion.
So when you come up to the microphone, please let us know your name and where you're from. Thanks.
Alex Rowe, Malaria Branch, CDC. This is a question for the gentleman from Burkina Faso. And this is really kind of a clarification. So you were making the argument that the school-age children are as much of a contributor to transmission as adults. And here's the clarifying question. Are you taking into account the proportion of the overall population that each of those two age groups represent? So in the pie chart that I remember, the slice of the pie was sort of equal between school-age children and adults, but for every sort of 100 people in the community, there are a lot more people over 15 than 5 to 15. So which does that take into account the?
Yeah. Yeah, definitely. We use infectivity data in the different age groups, also demographic data. So that's what I meant. So we accounted for the fact that more than 50% of the population be older than 15 years old, and also accounting for exposure. So there's three different factors: demographics, infectivity, and mosquito exposure in different age groups. So that's accounted for in the calculation. Actually.
Okay, so that means that that for kind of a given school-age child or a given adult, the school-age children are even more infectious than the adults because they're a smaller portion. Okay,
definitely,
that's good to know.
So I showed the infectivity prevalence. So that's the proportion of the population in different age groups that infect at least one mosquito. For the calculation, we actually use the proportion of mosquitoes acquiring infection if they fed in randomly selected individuals in each age group. So that uses all the infectivity data. So and children were much more infectious than adults, even more infectious than what is seen in that graph when you use the entire data set. So definitely, yeah. So they contribute similar numbers just because they're more infectious.
That's helpful. I think it helps strengthen the argument for school-based interventions.
Definitely, yes, thank you.
I think we'll alternate side to side for now.
Valentina Buch, UNICEF. So thank you to all the presenters. It's very interesting data and important for the policies that we within UNICEF and the WHO and other will take as uptake and think about how we will set policies. But I had a question because one thing that I saw was missing was really kind of the package and the context within which this is placed. It was very important that usage of bed nets, for instance, was very low, and that how do you really ensure the SBCC of also ensuring seeking care, because these are imperfect interventions. So even though we will see decreased parasitemia, possibly decreased malaria, children are still going to get sick. So how do you ensure that you then will ensure that their parents or they themselves or their teachers will ensure that they do seek care when they are ill?
That's an excellent question.
And MCP.
Thank you. That's an excellent question. Looking at, I'll speak a bit about the intervention we conducted, and then more, if you remember the last slide where we ask, how can we improve this? How can we make sure that the community gets the best out of this intervention? So our particular trial really went in to give the children IPT for 6 months. But this intervention should sit within a broader scope of interventions to get the best gain. And I'll explain a little about Uganda, what people are now coming to think about. We have school net LLIN distribution. That's something that's coming onto the board right now. And we are going to give out LLINs through schools, but it will have a school education program, which will be broader. So within that, there'll be messages to the children, there'll be messages to the parents on prevention, on using nets. So it's not enough to give DP or to give prevention. You have to accompany this with messages to both the teachers, to the community, to the health workers. So a school cannot be taken in isolation, but it should really be like a focus. And some studies have shown that children actually are a very good agent of change. So we need to just get together and do more. That's what I would say.
I just want to add one additional comment. One of the things that was striking about the presentations was I would say the overwhelming welcoming of the community and children in the school clinic, where you had the teachers testing and treating kids, and the challenges of doing IPT, even though, from a malaria standpoint, I would want my child to be protected against malaria now going forward. But somehow this basing treatment on sick children in a sort of almost like creating a school clinic was much better accepted. And I think it's sort of to your point that we need to take all of these things together, and what is more acceptable, what is more, what has the best access for children. And as we have more malaria interventions, more and more of the fevers are not going to be due to malaria, and we need to be prepared for that as well. So, go ahead.
Good morning. Paul Sakis with University of Florida, and previously and in the future with PMI. I really appreciate your panel, and I think it's an important and fascinating population. One issue that comes up I wanted to raise is using these school children who are on their own in the school without parents around as informants, and just wondered whether there should be or whether there is a consensus among the research community in terms of the reliability of that data. And I think it actually might cut both ways. I felt a little skeptical on Monday and today when there was data gathered on, did you use an anti-malarial drug, or have you had a fever? And picture a little 7-year-old, are they really going to be able to tell you that? On the other hand, when you find that the kids are saying that we use nets 36% of the time, and community, presumably adult respondents, are telling you 61%, it may be a case of truth in the mouth of babes. I just wonder, kids may be less informed but more honest. So it could be a challenge or an issue to look at.
I don't think I have much to add other than we agree that that is a challenge, and at least within our own work, we acknowledge that as a challenge, but at this point haven't gone sort of further to try to validate the childhood reports. We do have some data where we could look at that further in a school-based cohort that we did where we asked children, there's a time recall bias, because at the end we did a parent interview and asked them to recall treatment episodes for the prior 6 weeks. So we could look at that a little bit more, but I don't have any other data to address that question, but agree that it's a concern.
I think just to speak to the 38 versus the 61, you'll note that the 38 is coming from the school and the 61 from the community, but the 61 has children who are 5 and below. And in Uganda, as well as other countries, that's an age group that was targeted for LLIN. And even when you do the bigger surveys like MIS, you'll find that parents actually place these little children in nets. At times they're even sharing the bed with them, but the older children are generally uncovered. And then when you look at our data, looking at the school, that's 5 to 15. If you trace them into the community and stratify, you find that it's almost similar in terms of reporting of history of fever. So the kids reported, but even in the community, the parents report that there's actually the burden of disease. So that kind of settles your fears there.
Hello, my name is Crystal. I'm from Uganda. Another question for Catherine. And your slides, just a clarification, please. You had results from microscopy and from RDTs at some point, and there was a difference in the results. So I was wondering, is that microscopy and RDT, or did some places use microscopy, other places use RDT? And then I had a comment on, you mentioned some of the challenges of treating the children with the DP and so on, and one of the things you mentioned was the lack of trust in the community. And that is a big problem that we encounter all the time, but I had a suggestion. Since, we are giving suggestions, one thing that could help there is, did you consider working with like the VHTs, the village health team? Because we discovered that if you work with people that are well known in the community, it's far easier to build that trust and administer some of these drugs. So they may not trust the organizations that they see as coming from the government or something like that, but conversely, it was far easier for them to trust their own village members that have been trained in, in healthcare giving, even if, they are trained by, the government. But, so that is a suggestion that could maybe improve the application when you're trying to measure impact of some of these interventions. Thank you.
Thank you. The suggestion is well taken. And for the RDTs, when we went to the schools, during the survey, children who had fever, all of them would do the RDT. But then all the children would later have microscopy. So the RDT really was to give treatment on point, right there, point of care test. Yeah.
Luis Benavente, MCDI. I had a question about when the school catchment area and the location where you track the child actually live didn't match. So I wanted to know if you exclude children that live outside the school catchment area. You get my question? Is sometimes children take the bus or attend school in a different city or town, not necessarily in the same place where they live. So once you define the school catchment area, the school you intend to intervene, there may be children, particularly in peri-urban areas or when they have access to a road or bicycles, may go to other schools.
I think it depends where you are, but if you are, most of the surveys and work that is being done in school-aged children is going to be done rather in rural areas, very rural areas. And usually if you go to these schools, usually the catchment area is going to be villages around that. So the possibility of someone maybe taking a bus, yes, there might be few, but they are going to be very, very few, moving from one area to go into a different area to have education there. So most of these surveys, and I would say they actually are reflective of what is happening within the catchment area of that particular school.
Thank you. My name is Joanita Nankabira from Uganda, and I had a question for the last presenter. It's really a practical question. How are you finding getting the data from the different studies? I know the study-based analysis is easy from the papers, but the individual-based analysis. And has the public repositories helped you in that?
Thank you, Joanita. And thank you for your contributions of all of your data that has led the way for others. We have data from 10 of the 12 studies. We have individual level data. To your point, though, actually we received all data from the study authors. We were not able to use public repositories, although I think that is a great advertisement's not the right word, but encouragement to all of us to use the publicly available databases. And I think it's been clear that there's access to that for genomic type data, but there is increasing efforts to provide public repositories for epidemiological data that would make studies such as this infinitely easier. So yeah, as a research community, I hope we can all move forward with contributing data in that way. Thank you again.
Okay. Good morning. I'm Dorothy Achu from the Ministry of Health in Cameroon. I want to appreciate very much the work you're doing, and this is for us a very important intervention. But it will be also great if you help us to really prioritize the different interventions we have for malaria control, especially getting this on board. And the studies you've done, I'll come back to the context. I'd like to know the place of something like the community-based interventions, if there are community health workers in some of the areas. We're working with resource-limited situations that we need to weigh which intervention is more beneficial than the other. So if you have a school-based strategy, what is the added value compared to the community health intervention which we are trying to put in place and to address the entire population and not just children under 5 as it was before? Thank you.
So maybe just looking at what I described earlier on, which is treatment within the schools. You find that in most countries, especially in sub-Saharan Africa, community health workers are going to be involved in the management of, let's say, for example, for malaria. But unfortunately, this still is limited to under 5 children. Not necessarily going beyond the under 5 children because of resource constraints and all that. So I think it's important for all of us to start looking at the alternative ways on how we can actually outreach to as many children as is possible, especially now that we are seeing that there is a lot of risk for malaria within this school-aged group of children. That's where now you start thinking about alternative means of delivering this. But what you're saying is important as we think broadly on how we can sustain some of these things. So, for example, if you were going to have a school-based kind of case management, you would want to think, how do you link these teachers to community health workers? In terms of one supplies, how do you supply them, the teachers, maybe through these community health workers who are already doing this? How do you supervise them? How do you ensure that there is on-the-job training going on all, throughout? One would want to think to look at how best to link these up: community health workers, the community health strategy, and then teachers on how you should go forward with that. In terms of prioritizing, I think interventions, I think it really depends. As of now, bed nets are the priority in most of these, in most of the countries, and we know the evidence is there, and it works very well. But it's obvious that bed nets, even though they are being provided either through schools or through mass campaigns, they are not in greater use. So one would want to think as well, why is it that bed nets are not in much use within this school-aged group? What needs to be done in terms of increasing bed net use within that? But that should not as well stop us from looking at the various alternatives, which I think is what was being described here today. There are other interventions that needs to be thought of, and that could add quite a lot of value as well in preventing malaria within this age group.
And if I can just sort of add our plug also, is that the advantage of the school-based intervention may extend beyond malaria, right? Mm-hmm. So this is a population that's largely underserved in terms of both curative care and also preventive care. And so while we're talking about malaria now, and if you were in the National Malaria Control Program, you would be thinking about what is this intervention, how does its cost benefit weigh against all the other interventions that are in the toolkit. There are also other potential benefits for creating a system for care for this population.
Hi, my name is Scott Lefebvre. I work with Catholic Relief Services, and my question is similar, and maybe I can frame it a little bit differently, is that obviously, we're trying to convince, and to convince we have to make an economic argument that this deserves to be part of the mix. CRS, as with many other organizations, we're kind of at the last mile out there, with especially Global Fund monies out, distributing bed nets and doing case management, et cetera. We would like to make a case to the Global Funds, the UNITAIDs, others, PMIs, to say we should do more of this. And so I'm just wondering if you have, maybe just frame the question a little differently, do you have any recommendations on making that argument? Obviously, if I'm guessing correctly, there's not a lot of comparative studies whether these types of interventions are, what proportion should they, as was said, what proportion should this be? What's the investment case for doing this versus a little bit more of bed net distribution or a little bit more case management, et cetera? So I don't know if you have any recommendations for making the case economically, because in the end it'll come down to, are we actually working these into other interventions? I appreciate the comment from the presenter from Uganda saying, yes, this is part of a wider intervention, but the question, of course, is how much? Thank
you. There were some economic analyses comparing school-based IPT to other interventions in Kenya. So that's a resource that there has been some analysis that's shown some relative benefit. I can't recall the numbers right off the top of my head. But I guess I would like to turn that question around to others in the audience, because I think we have the PMI side, the funder side represented here, and it would be great to have dialogue both directions and have people on the funder side address, how do we turn this make the next step for a more compelling argument, what more information is needed. Does anybody from the audience want to comment on this?
We'll let you think about it while we have the next question.
What I can tell you from the PMI side, I don't fully represent PMI, but I remember PMI in its earliest days, and PMI clearly was not working in a vacuum. We were, there were, RBM and WHO were making recommendations, and we were trying to follow really we have been following really the control program's priorities. But I think they were often taking their cues from WHO recommendations or RBM. But the main point is that my recollection is that they were looking at interventions that were supported by data that showed impact on mortality. And so, there were a series of BedNet trials that were done that really showed fairly consistent results, that they reduced under 5 mortality. I think case management has always been kind of in the clouds a little bit because no one's going to not treat. And so, of course, you'll do that. Although the case management world has been bedeviled by the fact that a lot of care is sought in the informal sector and kind of governments don't know really how to deal with that. But the point is that I guess for lack of a lot of randomized controlled trials showing that treatment helps, there is an evidence base of sorts for that. And then IRS kind of falls into the same category as ITNs. And then IPTP similarly showed convincing, there were convincing trials that showed that it improved health outcomes for infants. So I guess the question is if school-based treatment or school-based interventions are, if people are trying to figure out where does this fit in, which I think is a fantastic question. I think if it's viewed through the lens of what was done in Malawi as a source of case management, in a sense, the teachers are becoming lay health workers, and there's nothing wrong with that. If they're improving access, to me, that's part of the case management kind of portfolio of strategies to get case management kind of rolled out as effectively as possible. Once you start getting into what's almost chemoprophylaxis, right? I mean, IPTP, if you do it often enough, kind of, right. I guess that's a different question altogether, I think. And I think you would need to show more than just a little bit of reduced parasitemia or anemia. You'd have to show, was it really reducing transmission? And if so, maybe that would be used in the context of elimination. Or if there was an impact on mortality, I think that probably would be difficult to show. But again, I think those are the kind of bars that you would need to achieve in order for it to be sort of fully embraced by donors. But that's just an N of 1. I don't speak for obviously the entire donor community.
Thanks.
Thank you. Hi, Hannah Conker from Johns Hopkins Center for Communication Programs. I want to congratulate all the speakers. I thought this was really excellent, and it's nice to see the progress in these school-based interventions. I'm a net person, and I don't mean to detract from that, but I just wanted to clarify a couple things in terms of the net use and how we look at that. We know from looking across multiple surveys that those under 5 groups are prioritized for net use when there aren't enough nets, and even when there are, quote unquote, enough nets within households, and then women of reproductive age also, and we have those lower use rates among the teenagers and the school-age children. So what I think is really important as you look in your community surveys is to ask the children in some fashion, do they have a net for themselves to use? Because I think, looking at the data here, if you had average numbers of nets per household of 1.96, school children probably live in families that are a little bit larger, and 2 nets or slightly less than 2 nets is probably not enough for everybody in that household to use the net. And so to Paul's point earlier, I think what we see in terms of the 30-ish% use rates among your school-age children compared to the 60% use rates among the general population matches almost exactly what we're seeing in these curves across different countries. So just to emphasize that looking at that access to nets is important as you consider whether these children have the opportunity to even use a net in their household.
Thank you. Any other questions or comments?
Yeah. My last intervention was a comment, not a question. So here's a question. For the studies that I saw that were where it was, I think, IPTP, or sometimes it was quite often, did I even see a study of daily mefloquine?
Yeah, that was the Weiss study from 1995.
Yeah, okay. Well, that's exciting.
And they had 2 sub-studies where they were doing really frequent dosing.
Yeah, I can imagine my 5-year-old, oh, you had another bad dream, I wonder why. So my question has to do with safety. If we're talking about these school-age interventions from children, let's say roughly 5 to 15, that's potentially a decade. My understanding is that we have relatively limited safety data on anti-malarials. There were studies on Peace Corps volunteers, which are obviously kind of adults they're adults, really. And so that was with chloroquine. There's sort of less, there is some data on mefloquine, although there's some questions about that. I'm not aware of a lot of other long-term safety evaluations of continuous use. I realize not all of them are sort of daily, but even still, if it's, even monthly, it seems like a long time. And if you're trying to improve, for example, academic achievement, is it possible that there's kind of some sort of safety signal that would potentially offset some kind of adverse event that could offset the benefits? I think that's also really, really important. You don't want to do any harm, obviously.
Thank you. For the START IPT trial, we did have some safety data from the children, but it's not really long term because this trial ran for 6 months. One of the methods we used is the teacher would do roll call and would ask the child whether they had any problems after taking the medicine, and we recorded all that information. So the children would report, maybe I vomited, maybe I had a headache. So you'd definitely have to assess on day 1 what were they like. This is day 2, day 3. But then we also did EKGs on a subset of the children, and we did not have any gross or alarming incidences with these children. We did have some children who would come up with a prolonged QT interval and would mark them, would flag them, don't give them more medicine. But generally, it was safe, but short term, not long term.
Yeah, I would suggest that future studies, if you're trying to map out a research agenda, pay a lot more attention to that. If you have children that are vomiting after a dose, if you give it to them the next time, what happens if they just sort of not take it, or headaches or something like that? I think this is a non-trivial issue. Thank you.
Now, just to say, there's the precedent of SMC that's now increasing up to 10 years of age. So those are seasonal IPT kind of scenarios where children are getting doses of drugs 3 or 4 months a year, probably not as long as we're talking about, for up to 10 years of age. But and there's a lot of interest now in increasing the safety data in general, particularly with the ACTs, for using drugs more frequently in pregnancy and so forth. So I think that's a very good point, that this is an issue that needs to be addressed as well.
Hi, John Painter, CDC PMI. Just a question about the strength of evidence. I'm wondering to what extent you have data on the individual children rather than just the school and the overall levels of parasitemia and net usage, because that could be just an ecological study and miss the fact that there's clusters of children that are more likely to have infections. Correct me if I'm wrong, but I think at ASTMH symposia on school-based programs last year, there was a study where all the children at one school were tested and treated, and then I think 6 weeks later they were tested again. And most of the children who were ill at 6 weeks later had been in the group that was ill to begin with, suggesting that there was a group that was more likely to become ill. And I'm wondering if any of the studies are assessing that.
I think that was a study that we conducted in Malawi, where we followed school children for 6 weeks and treated based on RDTs at day 0. And yes, did find that the biggest risk factor for RDT positivity at 6 weeks was RDT positivity at day 0. And I think it does point to other potential uses of schools in that we see that there is some heterogeneity even within the school populations. And that's in terms of a monitoring and evaluation piece that has been proposed for the use of schools is could you do school-based studies to identify hotspots of local transmission. So I think that's another potential use, and I agree that there is heterogeneity. I don't think that our meta-analysis will really be able to get at that fine a scale detail, but we will have individual level data in that analysis. That's a good question. Thank you.
Good morning, Gabrielle Hunter from the Johns Hopkins Center for Communication Programs. My question's for Dawn. Yesterday, in one of the case management presentations, we heard about one of the primary challenges with case management being behavioral, specifically the reactions of providers and patients to negative RDTs. I'm curious what kind of reactions you may have seen among the teachers, the children, or the parents of the children to any of the negative results.
Towards a negative result, meaning that if someone had a negative result and whether they were able to treat or not based on a negative result, right?
If there's any challenge, if there are similar challenges perhaps being observed in this setting compared to those that we've heard are important among healthcare providers and patients when they are faced with a negative RDT result.
Okay. All right. I think in our setup, one thing that we saw, especially amongst the teachers when they were faced with a negative result, we actually saw that most of them were actually following the negative result and actually not treat the children per se, which is completely contrary to what you see mostly amongst the health workers. In a sense that most of the health workers actually are going to go ahead and treat, even though it is negative, because of, well, I would want to assume because they think they know better and it's maybe the test is wrong, they think the test is wrong and all that. But what we saw in this setup is that most teachers would actually follow that. I don't think there was any aspect, maybe we just didn't follow up this, where people would say, well, I've got a negative result, therefore I'm going to go and run and get treatment because I haven't been given treatment there. We didn't see those kind of things in that setup. So for me, I think working with this group of teachers, I think you really don't run into problems of that nature. And this is not only teachers. Even when you think about community health workers in Malawi as well, you see the same pattern. Compared to clinicians, they will usually follow the RDT results and treat appropriately. Whereas when you go to clinicians, it's something completely different.
Not sure we have anything else, doctors. Anything else? All right. Well, thank you all very much for attending and especially for your active participation. This was a very helpful discussion, and we hope to continue it. Thank you.